We'll be seeing that we'll be recording today. So thank you for joining us, everyone. My name is Mary Jo Catras, and I'm with University of Minnesota Extension, the Center for Family Development. And we are here today to talk about Harm Reduction 101. And so this project, this webinar, is funded under our Great Lakes Rural Opioid Technical Assistance Regional Center, ROTA-RC for short, and it's funded under SAMHSA, and it is part of a regional project that we're doing that started late last summer, and it includes Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. So we're really excited to bring this region together to learn together and to share about our experiences and think about how we can continue to support recovery throughout our communities, throughout our states. And when we do these webinars, we really want to make sure when we're talking about substance use and recovery that we really want to emphasize that words do matter. And so when we do our education around this work, we use affirming person-first language when discussing behavioral health disorders that's not stigmatizing and recovery oriented. And so you'll hear us talk a little bit about that, and Laura will touch upon it as well, but that's really the values that we have, and we want to make sure that we are not doing any harm, and we're providing a safe space for these conversations. So thank you everyone for putting in the chat where you're from. I love to see where everyone is from, and thanks for joining us. And I am going to turn it over to Laura, but I'll say one more thing before I do that. Sorry, is we use the chat a lot. So if you have questions, comments along the way throughout the presentation, please put them in the chat, and I will be monitoring, and we can ask questions along the way. So note that as well. So Laura.
Thank you. Thanks, Mary Jo. So my name's Laura. I'm a pharmacist. I work at the University of Minnesota College of Pharmacy on the Duluth campus. And I've been involved in community work to address substance use for about 8 years now, starting with local coalitions and treatment courts, and then working with communities, people in recovery, working on different projects in collaboration with the Extension and rural and tribal communities. So it's always my honor to be here presenting. And I like to acknowledge the land that I'm on is the ancestral land of the Ojibwe Native American community in northeastern Minnesota. So before I get started too, also just want to say that the people that I've learned with the most, rural and tribal community members, really have formed my passion for this work. And so I'm really relying on what I've been taught because I was not trained as an expert except for my pharmacy degree, but really what I'm sharing is what I've learned from people in the field. So we're going to talk about the past and current trends in substance use, how they inform community-based harm reduction practices, the health and social benefits of harm reduction programming. We're going to identify and talk about different myths that are surround harm reduction. We're going to talk about the benefits and evidence behind harm reduction approaches, including naloxone, syringe access, fentanyl test strips, probably things that all of you have heard about. Naloxone is the same thing as Narcan. It's just the generic name. And then to implement strategies that reduce stigma and engage patients in care related to substance use disorder. So I know in the chat we have some folks that shared how they see harm reduction, and I can't see those because I'm the presenter, but generally they're right on. So feel free to take a look at that chat and see what your colleagues are saying their views of harm reduction. So we usually start with, I like to start with pictures. So take a look at these things and think about what do they all have in common. And actually, Mary Jo, I'm going to ask people if you could put in the chat, what do these tools have in common? And Mary Jo, maybe you can share a few audience responses.
Yeah, safety, protection.
Safety, protection.
They can save lives, lower harm, prevent harm, prevent fatality. Safety.
Excellent.
Devices. Lots.
Okay.
Thanks, everyone.
Got it.
Read them fast enough.
Okay, good. So we're getting this right. So these are all harm reduction approaches, right? So we have a helmet, a seatbelt, a fire extinguisher. We have the Gardasil vaccine, which is for HPV, to prevent HPV. So these are pretty much well accepted tools that could save our life. And we never know when we're going to need them, but we put them on, we use them, we have them in our kitchen. Like, we wear a helmet when we ride our bike. Are we expecting when we hop on that bike that we are going to get hit by a car and hit our head? Probably not, but we wear that helmet anyway, just in case, because it's worth it, right? Pretty much people accept that. Seat belts too. Most people, probably not all, but most people just put their seatbelt on when they get in their car because, again, if we expected we were going to get in a car accident every time we got in the car, we probably would never do it, right? But we feel like, you know what, this is a tool that has enough benefit where it does very little harm for me to put my seatbelt on, and the potential good could be life-saving. Same thing with the fire extinguisher. We don't just carry fire extinguishers with us all the time because we think there's going to be fire at that moment. You just never know. And if you had a fire, you would really want to have the fire extinguisher. Could save your life, could save your home, your garage, whatever it is. And then the same thing with vaccines. So these are well accepted tools for harm reduction. These are public health tools that our society has accepted. Probably because there's not as much stigma. So here are some other tools. So we have a box of Narcan nasal spray, which is Naloxone, is the generic name. We have we have fentanyl test strips, and then we have a sign about needle exchange. So when you think about these things again, they are also tools that save lives. It does no harm to carry naloxone with me. I carry naloxone with me. Absolutely no harm to have it around, have it in the first aid kit, right? Make sure it's in all the office spaces, all the schools. What is harmful about that? Absolutely nothing, because that can save somebody's life. And it's a nasal spray. So really the side effect of this is nasal dryness, right? Anyway, but these are harm reduction tools that are less accepted. Same thing with fentanyl test strips. Like, those can save people's lives. And we're going to talk a little bit more about all of these, needle exchange or syringe access too. But unfortunately, because of stigma, these things are less accepted in our society, and it can even be controversial. I was at a meeting the other day where there was a physician in attendance, and I was talking to somebody that was visiting to learn more about harm reduction, and I had a box of Narcan nasal spray for that person who was actually going to be traveling out of the country, and there was a physician in attendance, and he's like, "You can't give that to them." I'm like, "Well, why not?" He's like, "Because it's a controlled substance." And he was like really kind of upset about it. I'm like, no, it's actually not. It's not a controlled substance, but there's a lot of myths, right? Even among the medical community. There's actually a move, the FDA was just advised to move Narcan over the counter because of its safety profile and the public health benefit. So long story short, because of stigma, which really is just such a powerful force, unfortunately, these items here in front of you, which are also public health approaches backed by evidence, backed by data, save people's lives. Unfortunately, these are less accepted in our society. Because of stigma, approximately 80% of people with a substance use disorder will not get help for their condition. So this is absolutely something that we need to take a step back and look at. What kind of bias do each of us have? And really, all of us have bias, and it doesn't mean we're bad people, right? We all have our own biases based on our life experiences. For me, I grew up in a house with substance use. So I had a lot of bias. I didn't have the experience of ever seeing somebody in recovery. I only saw the experience of the harm that somebody with a substance use disorder can do to their family. So I actually had a lot of my own personal bias to work through. And thankfully, I'm always a work in progress. But all of us, depending on our life experiences, may have some thoughts about substance use disorder. So it's really important for us if we're not sure, like, sometimes if you've been around a lot of substance use, you might see it more as a moral failure versus a medical condition. And so if that's you, We're always a work in progress. There's a lot of data out there, a lot of research that can show us why substance use disorders are medical conditions and should be treated as such. Rather than as a moral failure. So again, these are tools just like the tools on the previous screen. These are public health tools that save lives. So are these, but because of stigma, our society is less accepting of them. So what is harm reduction? And I know there's some good answers, I'm sure, in the chat. But very simply, it's doing things that make it safer for people to participate in activities that could lead to harm, but are unrealistic to ban or eliminate. So riding our bike, driving our car, cooking in our kitchen, and then really like some other examples, can we realistically eliminate contacting other people? Probably not. We probably don't want to do that. So we have vaccines because we still have contact with other people. And sometimes they might have a disease that we have a vaccine that prevents. So going out in the sun is another example. Like, I love the sun. I didn't wear sunscreen for many years, and that was not a good decision. But we have sunscreen for people just to make sure that the harms that can come from the sun aren't going to be as harmful to us. That's a harm reduction tool. Same thing with driving. And condoms are another example. There's an advertisement here about how condoms and condom companies specifically have tried to help make them more acceptable. So again, I didn't have one. I didn't use one because I didn't have one with me. And the saying says on this advertisement, get real. If you don't have a parachute, don't jump. So that's just an example of how some harm reduction initiatives go. So we're going to talk about national drug. So I got to move my screen here. So this is a figure in front of me. National drug-involved overdose deaths, and it's the number between 1999 and 2020. So it's always hard to get to really recent data, but you can see on this graph that the total number of people that are dying from an overdose goes up every single year. And I usually like to say, if this is something, this can be triggering to some of us, right? If you've lost a loved one to an overdose, or maybe nearly lost a loved one to an overdose, this can be really hard to see thinking about these lives. And we need to remember that each one of these numbers is a person. This is not just a graph of some obsolete item. These are actually people who lost their lives to overdose. And we have tools that could prevent this. So this is really a horrible reflection of how well we're doing to address this epidemic and how powerful stigma is. Would we ever see a graph like this for asthma deaths? Probably not, right? Or heart failure, other medical conditions. And yet with drug-involved overdose deaths, we see those numbers continue to climb. And in 2021, I can tell you the numbers even higher because they have preliminary data. Actually, I think they have published data on 2021 now. So again, if this is you, our hearts are with you. That's why we do this work. We need to get control of this. This should be zero. And so we're working really hard to get things like naloxone in the community and to really try to treat mental health, because of course there's a tie between mental health and substance use. There's just a lot of work to be done and a lot of need to acknowledge the role of stigma. So again, of the overdose deaths, over 71% or 70%, and this number goes up every year, involve an opioid. So of the people that pass away from opioids, usually it's not just an opioid in the system. Usually it's an opioid and some other substance. So it is helpful, I think, if this is a new sort of area for you, it's kind of helpful to talk about the different waves of the opioid crisis. Because a lot of times people think that it's still pills, and it's really not. So I'm going to briefly go over this graph in front of you shows those three waves. So the first wave is the rise in prescription opioid overdose deaths, and that started in 1999. And so this really was a result of healthcare providers not realizing that opioids were highly addictive, and so there was a lot of prescribing going on. We didn't realize how addictive they were. We didn't realize that people were taking a lot of them. It was just the medical community kind of trusted some pretty poor research studies and felt assured by those without looking at real good data. Well, then we figured out that there actually was a problem. And that was, again, this is still kind of the pill era, is wave one. Then we realized, wow, these people are addicted to opioids. And so, again, the medical community, not really looking at what good data would tell us to do, decided to just start cutting people off and trying to wean them off their prescriptions too quickly. So that actually was not good. We had some healthcare systems that thought they were doing a very good job in getting people off opioids, but then when you talk to the treatment facility, like a few blocks down, they'd say, nope, they're actually not doing very good, because the people that got cut off their opioids then ended up turning to heroin. So that happened on a very large scale. So you can see wave two is the rise in heroin overdose deaths. People were getting cut off from their opioids too soon. They were dependent. Again, they are physically dependent on this opioid. If you take it away, the dependence is still there. And so if they can't obtain opioids through legal means and through their prescription, heroin is also an opioid that works on that same receptor. And so people were turning to heroin then when they were unable to get opioids. So we saw a rise in heroin overdose deaths starting in 2010. You can see the graph here. Those numbers climbing. And then the wave three is the rise in synthetic opioid overdose deaths, and that started in 2013. And I would say that's just gotten worse and worse, where we're seeing fentanyl in all of our drug supply, basically. Fentanyl's in cocaine, fentanyl's in methamphetamine. In some places, they found fentanyl in marijuana. So fentanyl is an opioid. It's a synthetic made in a lab. Apparently, it's not very difficult to make, and that's why it's so accessible. So as these numbers climbed, fentanyl has kind of taken over our drug supply. The other thing that's happening recently too, and I don't know that it's captured on this graph, but pill presses are now available online for purchase. So if somebody wanted to purchase a pill press online, and they had some fentanyl and they had some powder, they can make their own pills to look like pharmaceuticals. And so this is something that is unfortunately claiming lives of youth, I think, more than other categories of people, but it definitely claims a lot of lives, where people are purchasing drugs off the street that look like a pharmaceutical because they're stamped. They come from this pill press. They look exactly like oxycodone or Ambien, their sleeping medication, or lorazepam, their anxiety medication. You can buy a pill press to make anything. So they purchase these drugs off the street thinking that they are pharmaceuticals, when in reality they are not. They are laced with fentanyl, or they might be completely fentanyl. And so long story short, we're having people that are passing away from opioid overdose from fentanyl that don't even know they're getting an opioid. We have people that are usually stimulant users. They prefer methamphetamine and cocaine. They actually don't want an opioid. However, there's fentanyl in their drug supply. So that's another trend that we're seeing. And then the pills, there's been some attention lately to drug dealers using social media like Snapchat to be able to reach youth to sell them pills. So those are just some trends. I'll take a quick pause. I've been talking a lot. Are there any questions in the chat, Mary Jo?
There are no questions in the chat, but does anyone have anything they'd like to, any questions percolating? You can always unmute too.
I've got a quick question. Why, this is Kelly Delkey in the Wilmer Regional Office. Why do drug dealers push fentanyl if they know that it's going to take away, quote unquote, their customers? That is something I don't understand what their mentality is on doing something like that.
Yeah, I get that question a lot. Probably need to just add it to my slides. So again, this is where I learn from people in the field, and I suspect there's probably some people that are in the webinar that might have additional details beyond what I can share. But my understanding is, so sometimes drug dealers will add fentanyl to the drug supply to give their drug more of a kick. It's just a better high. It's a different high. You would think, like for example, you'd think that if a drug dealer sold a person drugs that ended up causing them to die, that people would then not purchase drugs from that dealer. However, we found the opposite is true. If somebody sells drugs that are found to be deadly and cause overdoses, there's actually a rush. People want to buy drugs from that dealer because there's this perception that those other people weren't smart enough, they didn't use smart enough, but I'm smarter than that. I can get the
Yeah.
best high out of this drugs without killing myself. And now we have people that are actually looking for fentanyl. That is their drug of choice now. So I think, I don't know. Maybe I'll take a quick pause. If anyone else has additional things to add that has joined this webinar, they're always a good learning opportunity. We have 90 participants. So does anyone else have anything to add for Kelly's very good question?
Sheila, you have your hand raised.
I just have another question. I don't have anything to add to this one.
Tessa added in the chat that fentanyl can be produced rather cheaply and with a variety of chemical variations.
Yes, there's a lot of different variants of fentanyl. So should we go with our next question?
Sure. Yes, Sheila.
Yeah, thanks. So my question is, if individuals are using a substance and they're not seeking opioids, but they're using, say, meth, and it contains fentanyl, then are these individuals becoming addicted to the opioid without knowing what they're addicted to? And then how do they go about feeding that addiction if they don't know what substance they've ingested?
Yeah, that's a very good question. So there are a lot of people that swear that their dealer would not put fentanyl in there. Like, I trust my dealer is what our partners in harm reduction hear a lot. Like, my dealer wouldn't do that to me. So that's where fentanyl test strips come in, because we suggest that people test it. Nope, sure enough, like pretty much anything you buy now has fentanyl in it. So yeah, we are finding people that were maybe methamphetamine users that then become addicted to fentanyl and actually end up having like withdrawal symptoms when they stop using that they didn't have before when they were just using meth. So I don't know if that gets to all parts of your question, but yeah, it's maybe just another way to get people hooked too, because it is highly addictive. Other questions?
So one question in the chat about just the expiration of naloxone and how long is the shelf life?
Oh, we're going to get to that.
Okay.
Long story short, expiration's 2 years after it was produced, but it lasts a very long time, like 30 years beyond its expiration date. So I'll talk about that when we get to naloxone. Good question. So let's get through these other slides and then we'll kind of focus on our harm reduction tools. So we're going to chat really quickly about the history. So we do in the United States have this relationship with drugs. It started with the war on drugs in 1971. It's been an aggressive and expensive project aimed at curbing drug use, but really not a whole lot has changed. So you can see, here's a graph. Teens, which are the most common age group to use drugs, or at least show little net reduction in drug use since 1975 per this survey. You can see here is a graph, percent of high school seniors reporting illicit drug use in the past month. You can see that hasn't changed a whole lot. Maybe it came down since a peak in 78, but it's really not reduced a whole lot. And then what about access? So per the Office of National Drug Control Policy, the prices of drugs have been falling dramatically. And we talked about accessibility. So it's easier to find these things. So between 1981 and 2007, the bulk price of heroin fell 93%. And that same time period, cocaine fell and the crack cocaine also fell too. So these drugs are cheap, especially when you compare them to pharmaceuticals. This effect, where crackdowns on drug production in one area shift to another, is called the balloon effect, and is often cited as an explanation for trends in drug availability. So we might crack down on one drug, but then it just makes the other drug, then people focus on the other drug. So people are always probably going to use a drug. Unfortunately, we talked about this in another meeting too. Like, it's unfortunate people will do things that harm them. It's really hard to get away from it. So, but one important point, we talked about stigma and comparing substance use disorder to other chronic conditions. And again, how do we frame this so that we are treating this like any other condition? And sometimes people have some biases and misconceptions when it comes to relapse. So when someone relapses with a substance use disorder, it might be more obvious, it catches people's attention, but people relapse with all healthcare conditions, really. So if we compare the relapse rate for substance use disorder to that with hypertension and asthma, they're all about the same, 40 to 60%. So the relapse rate for substance use disorder, 40 to 60, hypertension, 50 to 70, asthma, 50 to 70. Think about hypertension. So people forgetting to take their drugs, their maintenance medications. Same thing can happen for substance use disorder. We have maintenance medications. Unfortunately, they're not accessible to everybody because of bias and stigma in the medical community, which makes them view these drugs as something they don't want to prescribe, or maybe this population of people as a group they don't want to work with. What if prescribers refused to prescribe antihypertensives? So anyway, again, it comes down to diet and maybe exercise and medication for hypertension. Asthma is one I'm very familiar with. Having 2 children with asthma that are moderate to severe. There's controller medication, there's rescue inhalers, but there's things that happen that can trigger a relapse, such as upper respiratory disease. Just getting a cold can make your asthma flare up. Being exposed to allergens, all sorts of things. Maybe exercise. So anyway, for these rates, addressing substance use disorder relapse, long story short, should be an expected part of your work if you are working in this area. And if you have a loved one with a substance use disorder, it's a part of the recovery process. And again, this ties into stigma and shame. We really need to be honest that there's rates of recurrence for every health condition. We want people to be safe asking for help. So again, eliminating drug use altogether could be a very difficult goal, especially with laboratory science being so advanced. These things are easy to make and manufacture. So again, considering this, harm reduction offers tools to reduce the harms that stem from drug use. So really, where are we today? We're going to talk about some myths, and we're going to actually talk about the tools. So one myth is that harm reduction promotes harm to the community. So in fact, harm reduction programs are actually shown to be a cost-effective way to slow rates of HIV transmission in a community. We've had a big focus on harm reduction in the area that I work in Duluth. We actually have an HIV outbreak in that area right now. So we are very invested in harm reduction, trying to have more people work in that area, get more resources. And again, even better, harm reduction programs are shown to facilitate connections to social programs and support for people who use drugs. So they're actually more likely to enter treatment if they interact with harm reduction. Another myth is that harm reduction only enables and increases drug use. Unfortunately, this is something that is a more common myth within the healthcare community. And there is no connection between harm reduction and increased drug use. And that there's studies with naloxone. That's a common myth with naloxone with healthcare providers. Well, if I give somebody naloxone, they're just going to go out and use. In reality, if you know anyone who's ever had their drug overdose reversed by naloxone, it puts you in immediate withdrawal. So it's actually a really unpleasant state. People would not put themselves in that state on purpose. Naloxone is just a tool to save somebody's life if they are in danger of losing their life. And again, harm reduction groups typically offer used syringe disposal and hand out medical sharps containers. So their presence is actually correlated with fewer discarded syringes in public spaces, so less likely for people to get a needle stick. So I'm going to talk really quickly about naloxone. Naloxone is also known as Narcan. So it comes in a couple different dosage forms. It's a high affinity mu receptor antagonist. So what does that actually mean? It means it looks like an opioid in the body. So somebody consumes an opioid, whether it be taken orally or injected or snorted, the opioid floats along in the bloodstream, binds to these mu opioid receptors. And when the opioid binds, it basically turns off your body's desire to breathe. And so that's why opioids can cause respiratory depression. And then eventually somebody stops breathing entirely and then they don't survive. How naloxone works is it looks a lot like an opioid in the body. So you give somebody naloxone, whether it be injected or nasal spray, gets absorbed into the tiny blood vessels in your nose. Then it ends up in the bloodstream and ends up in the brain. Same thing, just like the opioid, except that the naloxone binds to the opioid's mu receptor tighter than the opioid. So essentially, once somebody gets naloxone, it kind of kicks the opioid off the receptor. And when naloxone binds to that receptor, it doesn't cause that same signal to stop breathing or slow breathing. So when you give somebody naloxone, they're going to start breathing again. If given early enough, you can save somebody's life. And it might be more than one dose. The only thing it does in the body is this one thing. So if you're wrong and you give somebody naloxone, maybe the two things we're looking for is somebody who's not breathing and who is non-responsive. If we give them naloxone and it's something else, not an opioid overdose, we're not going to harm them because all it does is this one thing in the body. It takes the place of the opioids on the receptors without activating them. It's safe even if there are no opioids present. However, important point, if you give somebody naloxone, and maybe you reverse their overdose, they might look like they're doing just fine. However, the naloxone only lasts in the body about 30 minutes versus most opioids can last in the body for many hours. So it's really important for that person to receive medical care because it's very possible and even likely with fentanyl in our drug supply for them to have a second overdose once the naloxone wears off. So they should definitely not be left alone. And if you can get them into medical care, that's the best you can do. Here's the products that are available. There's a Narcan nasal spray, an injectable generic. I'm just going to hold them up. Here's the injectable generic. The expiration date is usually, by the time you get it, it'll be like 12 to 18 months. However, naloxone, they've done studies and found it can work up to 30 years beyond its expiration date. So if you have expired naloxone, the best thing to do is to swap it out for a dose that is not expired. However, if you encounter an overdose and all you have is expired naloxone, we'd recommend that you use it because it's still very likely going to work. It might just be a little less effective. And that's the case with both dosage forms. So any questions about naloxone? Oh, also it needs to be stored at room temperature. If it's in your car, it's going to freeze in the winter, right? At least in our region, northeastern Minnesota, and probably the Midwest areas that we're having our folks join from. And if you leave it in your car in the summer, it's going to be exposed to intense heat. So any kind of exposure to different temperatures is not good for a drug. That being said, if your naloxone freezes and gets brought back to room temperature, it will likely still work almost as well as before, but we'd still recommend that you swap it out for a new dose. Questions?
So one comment from Marcy, I have heard that when administered, people will often become very combative because of the high they were experiencing has been taken away.
Okay, that's a good comment. So people can become combative. It's not a normal thing. It can happen. However, it's probably not because their high has been taken away, although there could be people that are frustrated about that. What people often do is called speedball. And so that's when you take an upper and a downer together. So an upper would be like methamphetamine, cocaine. A downer would be like heroin or fentanyl. And we know fentanyl's in most of our drug supply. So if you have somebody doing speedball, they have an upper and a downer at the same time. If we give them naloxone, we're taking away the effect of the downer. So now we're seeing the unmasked upper. So we're seeing somebody on methamphetamine, we're seeing somebody on cocaine. That is part of the reason why people could be combative. The other reason is people wake up and they don't know what happened to them, and there's a bunch of people standing above them. They might see a police officer. And so there's a number of reasons why people might sort of freak out when they wake up that aren't necessarily associated with them losing the high. Not saying that couldn't happen, but if there is a person that's combative, it could be for a number of different reasons. And they're terrified, probably. They have no idea what's going on. But thank you for the question. That when we do the myths and misconceptions, that's always one that's on that slide. So which is a good lead-in, we have a full 1-hour training on naloxone that we offer, a webinar on that. So I would highly recommend if you have additional questions about naloxone, just want to learn more about it. We have a whole 1-hour webinar. So any other questions before I move on?
Let's see here. So I'm not sure, did you ask this in the chat? I'm a little confused here. It says, I may have missed it, but are there significant physical side effects of receiving naloxone?
Oh yeah, okay, that's a good question. So there's two main dosage forms of naloxone. So there's the, and I'll show you them. So here is the Narcan nasal spray. This is a tester. So basically all this is you put it in somebody's nose and you push in this button, the plunger, right? This is a tester, but the real one looks just like this. The real one just comes in a foil pack. And then the other dosage form is the injectable. And again, the injectable is a lot less expensive. So when we do trainings in the community, we tend to give out a lot of this because it's a lot cheaper. We can save a lot more lives. So the injectable comes in little vials and a syringe. And so what we do is we use a syringe to pull the liquid out of the vial. So the side effects of naloxone are really based on the dosage form. So the side effect of giving somebody Narcan nasal spray is potentially nasal dryness. The side effect of giving somebody injection, the Narcan injection, naloxone injection would be an injection site reaction. So just like with the flu shot, when you get a flu shot, your arm might be sore. You could have a little red spot. Those are the same sort of side effects, and they have nothing to do with the drug itself. They have to do with how you give it to somebody. They have found pulmonary edema in people that have been given naloxone, but the pulmonary edema is a known result of opioid overdose. So they haven't been able to figure out, and they're pretty sure that it's actually a result of the opioid overdose and has nothing to do with the Narcan, but that was associated. And they have found that if somebody's given rescue breaths, that actually reduces the incidence of pulmonary edema. So yeah, there's, again, and if somebody's not taking opioids, the naloxone does nothing in your body. There's plenty of people. We also have this other dosage form that it's the dosage form that talks to people have accidentally injected themselves, because people do that. And of course it does nothing, because all it does is sit on that opioid receptor. So if you're not taking opioids, you're going to see nothing happen. And that is why there's a move now. The FDA was just advised by a committee to move naloxone to over-the-counter status because it has such a great safety profile. With other drugs, we really have to worry. If we gave somebody epinephrine and they didn't need it, we could actually cause them some harm, right? It's not just a safe drug. It has a lot of systemic effects. That is not the case with naloxone. So good question. So in Minnesota, and each state has their own harm reduction agencies that are working on this. And there might be harm reduction agencies, but there's other groups that do harm reduction. So sometimes harm reduction can come out of a pharmacy. It can come out of lots of different places. So in Minnesota, we have Rural AIDS Action Network, Harm Reduction Sisters, and Steve Rumler Hope Network. Those are the three main ones in our state. In Minnesota, the state that I'm in, it allows pharmacists to prescribe naloxone per protocol. And then, like I mentioned, there's that legislative move to maybe even move naloxone to over the counter just to increase access. The pharmacist to be in this protocol must be trained for this prescribing, screen the patient for understanding of naloxone, provide education. Pretty simple. It's a collaborative practice agreement. In Minnesota, we also have a Good Samaritan law, which is Steve's law. So basically this is a person seeking medical assistance. So if I'm using drugs with somebody, they have an overdose, I call 911, I am protected so that I can't get charged or prosecuted for possession, sharing, or use of a controlled substance. And this law was really to encourage people to call for help if there was an overdose situation. In asking more questions, because of questions from presentations like these, I did learn that if somebody has a felony on their record, that does not apply necessarily. But if you don't have a felony on your record, then you are immune. So again, here's some myths and misconceptions. There's the myth that it's a controlled substance. That is actually not the case. The myth of aggressive behavior after administration. We talked about that one. There's the myth of harm related to administration. Again, we talked about the side effects. And also like that if you give somebody naloxone, that you're enabling continued opioid misuse. So if I give somebody Narcan, they're just going to go out and use drugs. So I can't give them that because then I'm contributing to their substance use. That is just not true. People are going to use drugs whether or not they have Narcan. It just makes it more likely for them to survive if they were to have an overdose and have a chance at treatment. And then there's also the myth of liability. And I think as people learn more about how the drug works and its safety profile, there's less concern about that. So one thing and again, this isn't a full naloxone training. We have those. But it is important when you give somebody naloxone to get trained on where to give it. So the arm and the leg are places between the knee and the hip, in your thigh. sometimes movies and TV shows show people giving Narcan in other areas that are not appropriate. So that's why it's good to do a training so you know where to give the injection. The nasal spray is obviously very easy, but I would recommend that. We also have another harm reduction tool, syringe access programs. And so these might be called needle exchanges or syringe exchanges. They take in used syringes and dispose of them as medical waste, and then they give new ones out. And these are a really valuable tool in reducing the spread of HIV and hepatitis C, for example. They also might give out tools used to prepare drugs, naloxone, fentanyl test strips. They are a very good connection to treatment recovery. As I mentioned, people that access harm reduction are more likely to seek treatment and offer medical screening and help with wounds as well. So syringe access programs per the CDC save lives by reducing risk of overdose. They're associated with a 50% decline in HIV transmission. People that use syringe access programs are actually 3 times more likely to stop injecting drugs. And there's also benefits to law enforcement. So less need to clean up needles, no increase in crime, lives saved, and then a lot, like I mentioned, a lot fewer syringes in the community. Additional research findings, again, these kind of back up the CDC. Areas with syringe service providers are likely to have lower rates of HIV and hepatitis C. People who inject drugs are 5 times more likely under treatment, and they reduce healthcare costs as well by preventing HIV and hepatitis C. Another tool is fentanyl test strips. And so these come in when we give out fentanyl test strips through our grants. We have a Ziploc that has a couple strips and then a little vial of water, tiny vials, and then a little card that gives instructions on how to use it. So these are designed for testing the drug supply for fentanyl. So you take a small amount of whatever drug you're going to use and then test it for the presence of fentanyl. It does work with most fentanyl analogs. It's inexpensive. It's $1 per strip, and they're very sensitive. So again, these are really valuable if somebody maybe is a methamphetamine user and they're like, no, I don't have fentanyl in my drug supply. And then you test and you realize, oh, they do have fentanyl in their drug supply. So it's really eye-opening because again, there's people that think that because they're a meth user or they're a cocaine user that they wouldn't be at risk of opioid overdose. But in reality, anybody that uses any drug could be at risk. So more and more, like I said, straight supply contains fentanyl. Test strips and education help people to avoid life-threatening overdose. And they are, again, potentially less useful in areas where people believe fentanyl is in all the street drugs. So if they're already expecting it, they might not use it. Another harm reduction approach are supervised consumption sites, and these are sites for people who inject drugs to do so safely under supervision of trained personnel. They are also shown to reduce the volume of discarded syringes in the community, increase connections between people who inject drugs and healthcare providers. They save the healthcare systems a lot of money based on HIV prevention alone. There's a few sites in the United States, in New York and Rhode Island, and then there's actually a conversation about having one in Duluth. That's a group of people talking about that, and other areas too, I'm sure. But you've probably heard about them in other countries, Canada, Portugal, for example, and the data does support. The data supports them. It's just, I think, people's mentally, like, how do you get past your stigma, and how do we think about this as a public health approach? Another area in harm reduction is decriminalization. And this is basically when you're minimizing the social exclusion of people who use drugs and creating a climate where they're less fearful of seeking and accessing treatment, using harm reduction and receiving HIV and AIDS services. So one example is Portugal. They decriminalized illicit drug use in small amounts in 2001, which led to a reduction in the number of drug users, a reduction in new HIV infections, and a reduction in drug-induced deaths. So there's a slide. So decriminalization versus legalization. So decriminalization is when you remove criminal penalties for use and possession, not the same as legalization where you remove criminal and civil penalties. So citations for use and possession, it's not the same thing. And again, decriminalization, police give tickets for possession and make arrests if tickets aren't paid, versus legalization is just, it's legal. So New Jersey regulates and taxes marijuana just like alcohol, for example. So this is one kind of area of harm reduction. And then another one I wanted to focus on is we're seeing more communities investing in harm reduction vending machines. And this is one that I'm more familiar with because of some of the work in northern and northeastern Minnesota. So public health vending machines were first implemented in the United States in 2017 as a strategy to increase access to naloxone and sterile injection equipment. They found that it was associated with significant reductions in overdose fatalities. And this is an area where one of the communities that I work with is working on implementing harm reduction vending machines. We secured funding for it. It just takes a while to like build the machine, and you have to create like a planogram and send it in. And so it just takes some time, but there's different kinds of vending machines out there with different levels of capability. So it really, they can be, I think, as little as maybe $5,000 going all the way up to like 12 to 15 for the ones that we're looking at that have more sophisticated tracking and controls built into them. So if you have any questions about that, let me know. And so that concludes our formal presentation. I'm happy to take additional questions at this point.
So I think you've answered a few of the ones that were in the chat before, but one question, Sheila, that you had was when we were talking about the drop in price, did that coincide with synthetic manufacturing of opioids?
Oh, I think the price drops, that slide, that was like in the 80s and 90s. I think the what we've seen now with, so methamphetamine, and we were talking a lot about opioids, so methamphetamine is still the drug of choice for a lot of areas, right? Meth is still the primary concern. But now the issue is like even methamphetamine has opioids in it with fentanyl. So fentanyl has definitely been something that's taken off in the last couple of years, definitely the last 5 years. So the other drug, ballooning price, I think that was before synthetics became as common and integrated into our drug supply. Other questions?
Hi, can I just ask a question here, or do I put it?
Oh,
in
yeah.
instead?
Any question? Yeah.
Okay. First of all, I've been to Harm Reduction 101 before, and I thank you for doing these. I always learn a lot, and I'm reminded of other things, and also things change, so this is helpful. My question is about the vending machines that are maybe in the works up here in Duluth, and I do have a question about where might these be housed, and would they require money? I'm just curious about the some of the particulars of that. And thank you.
Yeah. Well, so the ones that we're working on right now, so we've had a lot of requests since we've been talking about vending machines. I have a list of people that are interested in them. So I think the interest is people that hear about it are interested generally. So, but the project that we're working on right now is with the Boys Ford Band. And so we have approval through our HRSA Rural Community Opioid Response Program implementation grant to purchase 2 harm reduction vending machines. And so where we're at with that is we have the approval from HRSA, which I believe we're the first group to get that approval through that funding agency. We had our tribal resolution in place before we attempted this, because we always get the tribal council's approval before we do these things. And so where we're at right now is we have a list of potential items to put in the machine. We have the approval to purchase the machine. We have the machines picked out. We know which ones we want. There's actually some traditional art that we're going to put on a wrap that goes around the machine. And so we have this list of supplies, and we have a community research council that needs to look at that list of supplies and decide what's going to go in it. And then once they decide what's going to go in it, then we purchase all the things and send them into the company, because they have to build the machine around whatever's going in it and make sure that it actually works. So some things that were on that list, and again, I don't know which will be approved by the community, but we had things like naloxone and fentanyl test strips, pregnancy tests, COVID-19 tests, maybe first aid kits, feminine hygiene products, some other things I'm not sure if they'll be approved or not, but even injection kits, bleach supplies, pipes, new syringes, things like that. So we'll have to kind of see what the community decides, but those are sort of, it's kind of a big list. And then there's been other communities that I've worked with that are also interested and just don't have the funding yet, but that are kind of staying tuned to our Boys for It project to see how we do that. And I also believe the Boys for It project, we might be the first group working on vending machines on tribal lands too. So yeah, so that's where we're at with that. You have my contact information, so if you want to check in with me in May, I think that was kind of our best case scenario. If we were able to get it started in May, that would be great. And then we're using our funding through HRSA and other sources that we're applying for to keep that vending machine full. And I should state, so of course this is in partnership with the Boys for It band, but also the Johns Hopkins Center for American Indian Health. They've been a key partner in this, and it aligns with a project that they have as well.
Thank you. That was great.
Diona, if I'm saying that correctly, you have your hand up, and then Jen.
Yes, I'm sorry if I missed this, but did you say what did you say you can get the fentanyl strips from?
So we order them, Mary Jo, what's the name of that company? They're pretty accessible.
It's BTNX. I can put it in the chat. Yeah.
Yep.
Yes.
So BTX, it's pretty simple actually. Like when I order Naloxone, I have to have a prescriber signature. Like you have to do some paperwork to order Naloxone. But with fentanyl test strips, that's not the case. We just order them by the box. And so they're pretty easy. I'm kind of hoping that pharmacies will start to sell them too, just to make them more accessible. But generally for funding agencies that allow you to purchase Naloxone, they'll also allow you to purchase fentanyl test strips. Sometimes they don't allow things like syringes, but they usually do allow fentanyl test strips. Hi, Gina. Gina has a question too.
Yeah. Hey, Laura, great presentation. So this probably is really a pretty simple question. And I've wondered, why do we think investing in a vending machine is a good idea? I was thinking about this, after our discussion that we had earlier this week, because I think the vending machines will offer the products for free, correct?
Mm-hmm.
Why would we just not have like I was at Dan Liu's office, the public defender's office, and they just had a little basket of things. And so why would we spend the money on a vending machine? Why would we just not have little baskets to have the stuff? Are we afraid, or do we want to keep track of what's being taken, or what do you think about that?
Yeah, so I think it's partially, I think there's lots of different answers. And one of the people that's on our team, I know is enjoying this, so I'd welcome her to join too, if she has anything to add. So I think there's the accessibility piece, right? So especially in rural communities where it's really difficult to get stuff. Maybe you don't have a pharmacy for like 30 miles, or you don't have a grocery store. I mean, a lot of these things, like where do you find a COVID-19 test in the middle of the night or at 5 p.m.? Like, so there's the accessibility piece. Like a lot of times people just don't have access. There's the cost piece, like people don't have money for a lot of these things. The courthouse could be pretty intimidating to some people. So not everybody wants to go to the courthouse, even if it's accessible. Like they don't want to show up there. They want to be anonymous. And that's not just because, so maybe some people that have like a criminal record want to be anonymous, but again, like you also, this affects everybody. So we have like business owners, like we have to think about that pretty much like anybody from anywhere in life can be using substances and are using substances. So maybe they don't want to be seen picking up Naloxone either, or clean, sorry, I shouldn't say clean, new syringes. And so I think it allows some anonymity. I think it allows for it to not be cleaned out too. So vending machines can be programmed so that you can't just clean it out overnight, right? Yeah. So Naloxone right now, a box of it's $47 when I order it. So so the vending machines that we're putting in, we'll be able to give people a code. So then we can track who's taking what, when they're taking it. We can see how empty it is. We'll know if it needs to be refilled. One person won't be able to take all the Naloxone in one night. And so And it gives us some data too. Like if we know all of a sudden, maybe we were selling or not selling, maybe we were vending like 2 kits a week. And then all of a sudden there's a huge rush. Like that might be a good indication that we have some fentanyl in our drug supply, or like a really deadly batch. You know, sometimes when there's a bad batch, like we'll see a lot of people really struggling. So I think there's a number of different reasons, and I'll take a quick pause in case the person that's a part of the team also wants to join and share any other reason why we would choose vending machine versus other options. I don't know if she's still here, and I'm so other organizations. So we've worked with an organization that's the rural piece, right? So rural communities, especially, like they just don't have access to a lot of this.
Yeah,
It's really hard.
I think
but even
having
urban.
Yeah, I think having it free and all of that stuff for people to have is great. And I see what you're saying, like having a vending machine provides, you know, access in places where it might not be as obvious what, you know, because you just don't want people to know what you're doing or whatever. Yeah.
Yep. Especially if you're selling, I mean, or vending things like chapstick and first aid kits. Like, who's to say if you're standing at that machine that you're getting naloxone or new syringes? So I think especially in rural areas, there's a lot of stigma. In certain urban areas, even when you know everyone, there's a lot of stigma too. So I think it's just another tool that we're looking at the data and seeing how it can benefit our people.
Laura, there's one more question. We have a few minutes. Let's see. Can you address the stigma that continues to exist on the part of the first responders who feel it is useless to keep administering Narcan when their perception is that users don't want to change?
Yeah, it's definitely not just first responders. I think it's a myth, and it's just a really frustrating phenomenon we see in all healthcare providers, to be honest. And I think that's where really like allowing people in recovery to share their story and really elevating the stories of lived experience, that people do get better. And yep, you might have 8 overdoses before you are ready to go into treatment. Like that doesn't mean that you're a hopeless case, and it doesn't mean that your life is less valuable. And I think unfortunately, sometimes it takes them like seeing somebody close to them going through this and realizing, oh my gosh, this can happen to anybody. This isn't just a bad choice they made. This isn't them as this other type of person that, you know, so recognizing the humanity of the person, recognizing that it is a disease state, right? Like, and so until they get help, this is going to continue to happen. It's a part of the expected trajectory, but there is hope. There are people that get better, and sharing those stories of recovery. And I think building up the recovery community so they feel like powerful in sharing those stories is one of the approaches we're taking that I think is pretty helpful. We have a partner, Recovery Alliance Duluth, and their logo or motto is "Recovery is real." And so they're out sharing their stories and like having these fun events and really like building up their members, and that recovery can happen at all stages. So I don't know if that helps. But I think that the stigma, like that is one of the reasons when we do naloxone trainings, I always talk about stigma. What's our own bias and stigma? And people do get better. So no easy answer.
Thank you, Laura. I think that is all the questions, but if anyone else has any that I missed, please unmute and ask. But right now I just remember, I'm like, oh my goodness, I forgot to put the evaluation in. So there it is, the slides, presentation, certificate of attendance, and the evaluation link will be sent out afterwards. We have to get the recording captioned, so it takes about 24 hours, but then once that is, it will also be, it'll be sent out. And then Laura, if you go one more slide. This is our mailing list if you'd like to join, and also that you ensure that you get a certificate of attendance. We do have a list of all of you that signed up, but just in case. So if you have questions, please, you can also reach out to that as well, website. So, okay. We want to be mindful of time, but I think always we stay on for a little bit longer in case there's extra questions. But thank you so much for joining today. It was a great group and great questions. We really appreciate that. And as Laura shared, we learned something. I learned something every time I help to support and facilitate some of these webinars. So we're always learning together, right? So thank you for joining, and look for more webinars to be offered in the future. Thank you.
Thank you.
Thank you so much, Laura.